Thank you all. This is actually a very superficial component of all the orbital and oculofacial work that we all do, but it is an essential part of it as well. Even if you don't do aesthetic procedures and aesthetic surgery, you can actually innovate and improvise and use a lot of these techniques for your functional patients, and that's your learning ground for your aesthetic patients, keeping in mind that for oculoplastics, it is a fine line between functional and aesthetic, and even functional surgeries are always done with aesthetic indications in mind. No conflict of interest in any of the products that I mentioned. So why are we doing it in terms of aesthetic medicine and aesthetic surgery? Beauty is very subjective. You may think this has got bulgy eyes, but the frog thinks that actually the froglet or the Miss Frog is actually very beautiful. So this is where there's a huge conflict, because you may look at a patient and say, oh my God, she's perfectly fine. But the patient may think that this is not right, that my brow is too low and I want this brow up as well. And finding the balance between delivering what the patient and or the family wants to what you can do and what price you're willing to pay is very, very important. And beauty is also very subjective, and it has ethnic variations as well. Yes, there's a pan-Asian face, there's a pan-world face as well. So extrapolating one patient's facial anatomy to another person is very different. Knowing what they want and see whether the nose and the lips and the eyes are harmonious to the rest of the faces is actually very important before you can do it. So where do tissue fillers come in? If you have the peaks and the troughs, so on and so forth, and if you look at a child's face as an adult's face, and that's seen over here, later on I will probably show it to you. The purpose of a tissue filler are basically substances, could be autologous or a synthetic material, where you're trying to even out the surfaces so that you don't have the furrows and grooves, which actually plays a role not only in surface configuration, but lighting, which kind of tells you why somebody's got dark circles and bulges and so on and so forth. And that's where tissue fillers really come in. So what are the tissue fillers you should be aware of? There are natural fillers, which is what we use in functional surgery, including anophthalmic sockets. So every single time you put a dermosphere graft, it's a tissue filler. You're harvesting from somewhere else and putting it in as well. And there are synthetic fillers, and by default we move towards the synthetic fillers, which are hyaluronic acids, and they come in different companies, different trade names, and believe it or not, there are names of companies that are being having facial injections done, and they don't even know what names of products these are. And it's important that you as an injector should ideally give the patient the information, because some fillers have more complications than the others for later on manifestation as well. So examples of various fillers that we use autologous fat. We don't use heterologous fat. The most common synthetic filler that we use is Restylane, but there are other Juvederm and a lot of other products as well. Molecule size keeps varying depending on how deep or how superficial you want to inject it, whether it's for fine lines or deep lines as well. And of course, there's more semi-permanent fillers like calcium hydroxyapatite, which is Radiesse, which we sometimes use in certain situations. So if you look at aging as a whole, everything from skin down to the bone changes. But where fillers address is the concept of lipoatrophy, which means there's loss of fat as you grow older, and lipodescent, where the fat descends to the rest of the face. And that picture kind of shows you where the various fat parts of the face are. So why do we like a nice chubby little child and we all like to pinch their cheek? It's because of the fat on the face. It's a fat on the face which actually we lose over time, and it's like a dried orange or a lemon. It's all crinkled and wrinkled, so on and so forth, and you won't even buy it in the market anymore, right, if it's dry and crinkled. So the tissue fillers basically goes and re-inflates the various tissues of the face so that you can give the smooth contour to the face. And when you look at the 5 goals of rejuvenation, we are talking about relaxing, which is what Omar did a great job over talking about muscle relaxants, botulinum toxin and various other Dysport and other products as well. Then you can refill where the hollows are. You can do that with tissues from the periorbital or facial region, or from somewhere else, or from synthetic material, which is where tissue fillers does it. Every once in a while you can tighten the tissues with radiofrequency devices. And finally we'll talk about facelifts and brow lifts in the later talk itself, where you're releasing, raising, and repositioning these, and that's where surgical comes in, and that's where the holistic aspect of facial regeneration. So what are the indications? There are functional indications, aesthetic indications. Hollows from post-traumatic scars and deformities are good indications. Anophthalmic sockets with sunken deformities will showcase examples of good deformities. An extension of the same are these furrows, which are deep furrows, which are not dynamic but static furrows, can be filled up with fillers, but be careful about complications. The most common indications are periorbital in the tear trough deformity, and every once in a while in the lower face itself. Examples of patients who have superior sulcus deformities, where you can actually inject fillers to kind of deliver the fullness that you want to create, without going too deep inside the orbit. These are synthetic cosmetic indications. This is an anophthalmic socket patient. The filler has been injected a little too superficial. You don't want to inject too superficial. Instead of going and exchanging an implant and putting a big implant with the downside and the risk of implant exposure, so on and so forth, you can do this for your patients in your clinic, all under topical anesthesia or even no anesthesia at all. Patients like these who are anophthalmic sunken sockets, again, who are averse to having additional procedures being done, and you need a long-term benefit. You use a semi-permanent filler. This is Radius, which we injected into the orbit, inferior orbit, to pull up the superior sulcus, so on and so forth. And on CT scan, it's visible compared to a hyaluronic acid, which is visible in a different manner completely. And patients like these who had multiple socket reconstructions, and any amount of new fat you put in, and I think Dr. Allen talked to us yesterday, is very unpredictable how much fat uptake is going to be there. Once again, is a good candidate for semi-permanent fillers. The way I do it is I inject normal saline to the socket, look for superior sulcus deformity being filled up and completed. It gives you an idea what is the volume of filler you may need to inject, and then go ahead injecting as well. Till date, I have never injected tissue fillers into a seeing eye socket. But there are people who do that as well, and I don't have the guts or the insurance cover for that yet. And that's the kind of fullness you can get with just tissue filler injections in the outpatient setting itself. Post-operative, post-injection images just to showcase where these fillers go, where they reside. These last for a long time. Another post-blepharoplasty patient who had an asymmetric eye bags. I don't know whether you know. She was operated by a top-notch surgeon, and you can see residual eye bags on the right side. So we did a fat reduction blepharoplasty, and using her own fat, we actually used that as a fat pearl graft into the teardrop deformity, which is overcorrected, an aesthetic patient with a fat graft itself. Here's a patient who lost his eyelid, canalicular system, the globe, so on and so forth, and after multiple surgeries has a residual facial deformity. And for him, putting an autologous material is the ideal choice, where they're going to have rest of the face to be reconstructed. So we do a autologous fat transfer for these patients. The post-op doesn't show up. The most common indication, however, is a teardrop deformity, which is easy to treat. But these are patients who are nightmares to manage, and nasolabial folds, which again doesn't last as long as you would do a teardrop deformity itself. But when you inject anything into anybody's face, or when you even operate on patients, beware of the complications. And that's where the concept of informed consent comes in. Thankfully, most of them are minor and can be reasonably solved, but every once in a while we see nasty complications, the worst being blindness. We have seen fillers-related blindness even for injections done to the temporal area, because the textbook anatomy of the vascular circulation that we see of the face is very different from that patient's vascular anatomy. We have seen in ophthalmic arteries arising from branches of the external carotid artery, which if a resident taking examination says that in the examination, the examiner will fail them. But the truth is, if you do intraarterial chemotherapies, the truth is if you do AV malformations, you do selective arteriograms of the internal carotid artery system and the external artery carotid system, you'll see numerous blood supplies which actually feeds into the internal brain circulation and the ophthalmic artery itself. And the sad part about tissue fillers is even if you aspirate before you inject, unlike local anesthetic where there's a blood draw in, because of the resistance, you really don't see any blood draw in, and you may think you are extravascular, but actually it can be intravascular. And people have tried to overcome that by using cannulas rather than injections, but I have seen patients with severe complications even with blunt cannulas rather than syringe needles as well. So anyway, the next most common thing are inflammatory reactions, and I'll show you case and examples, and the worst is intra-arterial injections causing blindness. Here's a lady, believe it or not, she relocated to Asia Pacific from the Middle East. She was a global, high-flying person and developed a lump in the medial canthus. You put your finger on the medial canthus, there's a lump over there. First thing is mucocele and so on and so forth. Then you ask them, have you had anything done, any surgery done? She kept denying every single thing. So we had to go ahead do an imaging for her and demonstrated the soft tissue mass in the medial canthal area. And as she denied everything else, we had to go do a tissue diagnosis, and that's a hard lump that we removed, and that was a foreign body granuloma. Believe it or not, this happened about 2.5 to 3 years after the injection. Then when we prodded her with the information, she said, yes, I've had an injection before. How many? 3 different injections over 5 different years. And she couldn't even name what filler injections were given. So you should be careful about the various complications that can induce and be aware of the long-term and the short-term complications, and the most important thing, be aware of the arterial circulations, which connect from the extracranial to the intracranial circulation. Thank you very much.